And as the screen just told you, we will be recording today's meeting and we'll put it up on the website for everybody's viewing later. So I will hand it to Joel to give some quick budget updates, and then Tyler will have you begin to speak after that.
So hello everyone, just some quick house cleaning. I just wanted to touch base on some of the issues with spending going into fiscal 23. Just to let everybody know that we are, we did a really good job spending in fiscal 22, but in doing so, we got a little ahead of ourselves. And so some of the money is going to be moved around. And so some of you may have got emails from Becky or myself regarding some of the July invoices and maybe even some of the August invoices, just to make sure everything fits now that we get all these final bills paid. So just a heads up, if you have any fiscal questions around that, we'll be reaching out with you guys as we usually do, whether it's, weekly, bi-weekly, monthly in our normal meetings, that we can certainly circle back and get into the weeds with that if anybody has any further questions. But just a heads up that was a good thing. That might seem like a complicated thing, but it was really just to ensure that all the final bills were paid and that moving into the 23 contracts, that everything was happening. And then what we're also going to be looking at doing is going back into doing those quarterly snapshots, basically, to kind of show what lines are being spent, kind of how things are looking, so that you as the jails have more regular understanding of exactly what lines are spent and to what extent. And so then that way we'll have numbers that match up a little more consistently throughout the year. So just a heads up on some of those things. All right.
Okay. That being said, we are going to jump right into our first presentation. I will have Tyler introduce his team here momentarily, but just to introduce Tyler Marsh to you all, brings over 15 years health insurance and experience in Colorado hospitals and clinics. Prior to joining HCPF, which is Healthcare Policy and Financing, in February of 2022, Tyler worked with psychiatric populations at Denver Health and Children's Hospital. He has also served IDD populations as a case manager and a health insurance instructor at National Jewish Hospital, or National Jewish Health, excuse me. Tyler earned his Master's of Public Health in 2011. And as I said, I'll have him introduce his team. And with that, I'll hand it to you, Tyler.
Thanks so much, Kelly. For those of you that I haven't met, my name is Tyler Marsh. I'm a unit supervisor with Healthcare Policy and Finance. I supervise behavioral health safety net reform. What that means is that I'm involved in several projects across the scope of healthcare policy and finance, namely criminal justice partnerships in this scope, value-based payments, as well as high-intensity outpatient treatment, and what that looks like for community providers. And with that, I'll pass over to some of my colleagues, namely first Danielle McKibben.
Hello, everyone. I'm Danielle McKibben. I'm the Care Coordination Administrator under Tyler's team. So I'm helping look at where gaps are and figure out how we can better the care coordination to help ensure that members are not ending up in the psychiatric hospitals, where we can help manage them through better care coordination within the community.
Awesome. Thank you, Danielle. And Hannah?
Hi, everyone. My name is Hannah. I just started about 48 hours ago as the Criminal Justice Policy Advisor on Tyler's team. My background is primarily in direct care as a case manager with Colorado Coalition for the Homeless and with the Office of Alternate Defense Counsel, working in both places with folks who are justice involved. I'm excited to get working with you.
Thank you, Hannah. And Jay, are you on this call?
Hi, yes, I'm here. Hello, everyone. My name is Jay Jackson. I'm the grant specialist on Tyler's team. I have worked in the state government for about 4 years now. I came from the Department of Labor and Employment, where I worked on grants there. A lot of what I do is project management, ensuring the documents are released on time, getting the stakeholder input, and ensuring fiscal integrity of the grants. That's it.
Awesome. Thank you so much, Jay. So as you can see, we have a pretty diverse team, and it's my pleasure just to bring, a high level overview of some of the projects that HCPF is working on in relation to jails, corrections, and the justice involved system. So at this time, I'm going to go ahead and share screen. All right. Let's see if I can. Okay. So at this time, just a quick update. These are some of the numbers that HICPUF has collected. And certainly these are subject to change, but we are seeing that the incarcerated Medicaid benefit, and we'll talk about this in future slides, but as populations transition into the justice system for a short stay or for a longer stay, what we're really running into is the challenge of re-enrolling them or reactivating their Medicaid membership. So some of these numbers, Department of Corrections or prison, we have about 20,000 individuals, between 400 and 600 releases per month. In community corrections, halfway houses, parole, etc., we have 9,000, 10,000 individuals per year. In the judicial branch, probation, pretrial, and problem-solving courts, this is in Denver and around the state, we have 70 to 80,000 individuals per year. And in jails, we have 12,000 incarcerated with 80 to 90,000 booked per year. So as we look at some of the collaboration pieces, what we're really looking at here and what we hope to lean into more as the years progress is some of these data sharing agreements. In 2018, we signed a data sharing agreement with the Department of Corrections. We have a monthly collaboration with the DOC, RAISE, which are regional accountable entities, MCOs, and our other community partners. So far, and we don't expect this to translate, but we have found notable success with the Department of Corrections. We've really found that, there's a really great workflow with DOC and their benefits acquisition team. One way that they do this is through the performance full metric. The BH engagement with is within 14 days of release from DOC. And from that, we really try and emphasize our community corrections partners, as well as the RAISE within each of the regions around Colorado, as well as MCOs. And some of this comes into county work that you might see, but we really do try and lean on the jurisdiction of the RAISE in each of those counties as folks are released from DOC. From the judicial branch, we also have a data sharing agreement. It's modeled after the DOC and it was signed a little later, but what we're really working on here is some of the automated processes. We do have some challenges. We understand that there's going to be lower eligibility. We understand that we have less access to members or possible members. Just because they enter the judicial system does not mean that they might be entering the jail or the DOC system. So we have some challenges there with Medicaid enrollment. We also have less medical information. That's a little challenging when we start to extrapolate, what a member might need upon their release or what they might need when they're in the judicial system. We also have larger population, and in the challenges of the counties around the state, we also have 21 different judicial districts. Some of them, are interested, in the state collaboration. Some of them are less interested. So we do have some challenges, but we have found, some notable successes. So when we move on to the jail collaborations, and this might be more pertinent to this audience, what we're really seeing is that, we have 60 different jails and different political systems around the state. This is some of our largest population, and certainly a target audience for Medicaid enrollment and re-enrollment populations. Right now we have lower eligibility, but this is a notion that HICPUF notably is really looking to lean into. Because of the notion of shortest relationships, we do have little to least information about health need and history. Historically, there's been less formal collaboration with HICPUF, but per this presentation and going forward, that's something that we would like to change. Metro counties do have more resources and will for collaboration. I can't say that they have more funding, but certainly because of the nature of how much population comes in and out of their systems, they might be allocated more funding, but there has been a history of the state providing previous financial incentives for agreements between jails and counties. So one thing that we definitely want to stress is Senate Bill 22-196, health needs of persons in the criminal justice system. This gets a little bit into the weeds of some of these things, but one thing that we definitely want to stress is this has prompted healthcare policy and finance to update guidance for counties of eligibility workers. Just to make this clear, we are updating the guidance that these workers can determine a person is eligible and enroll them in Medicaid while they are still incarcerated. what this means for jails is that if jails know when an incarcerated person will end, the person is releasing, we are asking that you notify the county to enter that date as the end date of the in-car span. One of the challenges that we do have is that upon booking, sometimes that in-car status is entered. And what that means is that the Medicaid system then enters that as Medicaid is suspended and in-car is activated. And so what we're asking is that per this guidance and per county workers, when you know that person is going to release, you can enter the release date as the day prior or the day of, so that when that person walks out your door, they have full Medicaid upon release. Again, the focus is on ensuring that these individuals are enrolled and active prior to or on the release date. And again, we're working with community agencies, we're working with counties. The contact on this is going to be Matt Pfeiffer, and I'll have his contact information at the end of this presentation. But we are working on updating these guidance systems with county and, like with county DHS around the state. All right. So 2.01 behavioral health community support grants. This is an opportunity, and I don't want you to be confused by the number. 2.01 is just an internal designation referring to American Rescue Plan Acts. This is the grant funding that we received from the federal government to the tune of over 500 million over the span of several years to improve the behavioral health system. 2.01 just is an internal designation and refers to a project plan. For this specific plan, this is a grant that's in development. This is a grant total award of 14 million, but each awardee will be receiving 2 million. And this is to specifically keep individuals out of institutions. And we define institutions as inpatient hospital settings, incarceration, jails, and prisons. And what we're really striving for is this money will be to support persons transition from these settings into the community. And what we are hoping for is that in these community settings, these persons will utilize high intensity outpatient treatment. And to specify that, we have the current outpatient treatment of IOP treatment, which is about 6 hours per week in an outpatient setting, an outpatient clinic. We have inpatient residential, which is 24 hours a day or an incarcerated setting. And then right in the middle, HICPUF is aiming for high intensity outpatient treatment. This is an outpatient setting. We're looking at 18 to 19 hours per week per client. And we're hoping that this can be provided by outpatient providers and outpatient clinics. So again, 2.01 supports high intensity outpatient treatment. It's part of the grant requirements. And we're also asking that applicants consider, like a sustainability plan when they consider this funding. But again, the idea is we're looking at under-resourced and underserved populations. This could be in rural, this could be in frontier communities, but certainly in some of the counties where your facilities might be, like as folks release back into the community, we want those supports to be there. And that's what some of this grant funding is for. So if you have any other questions about that, my contact will be in the chat, and certainly anyone on my team can help you out with that. This is another opportunity. This is 3.07. This is wraparound support for members with complex needs. This is a statewide pilot in partnership with HICPUF and DOLA, Department of Local Affairs. And again, this gets back to the same point of when individuals, Medicaid members specifically, when they release back into the community, at a high level, we can understand that social determinants of health might lead to better outcomes, but ultimately, when folks release, they really need to have some place to go. And so what this is identifying, what this aims to do is to provide, those housing supports across the state, so that those members, especially with complex needs, especially, from my experience working in the hospital system, like repeat hospitalizations, serious mental illness, or a history of homelessness, they might be good for a few days and might have a medication, and then we see them right back in the system. So at the state level, we are really addressing that. We really want to take our funding, and see if we can evaluate some opportunities across the state, see if we can end that recidivist rate. And this last project, this is a collaborative that we have with the School of CU Medicine. This is called Jail Transitions of Care. And I'd be happy to share the executive summary on this. Ultimately, the objective of this is a pilot across 5 years. This is a pilot with Arapahoe County Jail. And ultimately, the goal is to increase access to, retention, and community-based medical care and social support for county-based detainees. What we're really seeing is that as these folks release, either from Arapahoe County Jail or from other county jails, they need some medical support. They need some medications, maybe they need some treatment, and they might have a great connection inside the system, but then once they're released into the community, they don't have those connections. So they can't figure out how to get there. And so what this aims to do is to establish those connections inside the jail system and continue that connection either through the same case manager or the same connection once they release back into the community. Again, this idea is to prevent that lapse in medication or treatment coverage for some individuals that might seriously need the same medication and the same treatment in order to have successful outcomes. Also, what I should note, there is another project that's not included in these slides, but one thing to bring to your attention, we have an opportunity, it's called Innovative Tech Integration. And what this aims to do is to identify TBI diagnostic procedures. And without getting into the weeds too much, that just means traumatic brain injuries. And what we are hoping to do is to identify best practices to identify and screen for these individuals before they leave jail or incarcerated settings. What we found and through our data is that incarcerated individuals and populations have much higher rates of TBI than the general population. And it's something that is concerning to us, it is concerning to providers that are out in the community, and so we are aiming to partner with jails and also with counties to identify ways that we can best assess and treat some of these individuals before they're released into the community, especially if they have some of these higher needs. And this is just a list of contacts. Again, my contact is right there in the middle. My colleague Hannah Hall will be assisting me on most of these criminal justice policy work. And if you haven't met Matt Pfeiffer, does quite a bit of work for healthcare policy and finance, works a lot with the RAIs as well as with the counties for criminal justice. And of course, Meredith Davis. She is Behavioral Health Special Projects Manager and supports our work leading into criminal justice partnerships. And I will go ahead and include all of these contacts in the chat.
Very good. Tyler, thank you so much. We were just kind of, another colleague of mine and I were sort of talking offline how sometimes we all just get so siloed, but there's so many things out there that are available to all of us. And so we really appreciate when this stuff is brought to all of our jails' attention, just so that they know there's a lot of things going on out there at HICPUF, at the BHA, everything. So it's great information. So thank you all so much, and appreciate you putting your contact information out there for everybody as well. So absolutely.
And just to reiterate, we understand that each jail and each county, runs with its own jurisdiction. However, at the state level, at least this year going forward, we would love to partner with you to re-enroll some of your folks, and some of our folks in Medicaid, so they have those services, so they can make healthy choices and ultimately be successful and stop that cycle of recidivism.
absolutely. Thank you so much again to all of you for being here with us today. So we will go right into our next presentation. Brianna, I just want to make sure you are here.
I'm here.
You're here. Great. Okay. So this is Brianna Hurd. She has a background in care management and service coordination. During graduate school, she transitioned into administrative social work. She has a few years of experience, of volunteer experience in the harm and risk reduction realm. Today, she's going to be presenting on fentanyl test strips and their uses to reduce fentanyl poisoning and overdose. She is currently the harm reduction and treatment program manager for the state opioid response grant. So with that, Brianna, I will hand it over to you.
Great, thank you so much. I am going to, so Kelly, I sent you my slide. If you're the host, do you mind sharing that for me?
Let's see.
I just made you co-host if that's helpful.
Perfect, thank you. Good to see you.
Yeah, you too.
All right. Okay, so yeah, my name is Brianna Hurd. I'm here to talk about fentanyl test strips. I am the Harm Reduction and Treatment Program Manager for the State Opioid Response Grant. And I just want to give you an overview of what they can do. So fentanyl test strips, let's start off and just flat out there for urine testing. This is a secondary use that someone figured out. We can test illicit substances for fentanyl. They help detect the presence of fentanyl in the substance, and this can encourage the person to either use less of the substance or not use the substance at all. And this really depends on the person's opioid tolerance. So if you have somebody whose drug of choice is not an opioid, so not fentanyl, not heroin, not a prescription pill, you can offer this as a tool to reduce the risk of opioid overdose because there's contamination in other drugs. So we're talking like cross-contamination in methamphetamines or cross-contamination in drugs like MDMA, ecstasy, Molly, that category. So that's a really great way to focus this messaging, is that if somebody has either lost their opioid tolerance or has none at all, we really want to encourage them to test whatever substances that they may be using, and then also providing naloxone alongside of that. And of course, the overall goal is to reduce the risk of opioid overdose. Different substances do require different testing dilutions and methods of testing. You know, right off the bat, if somebody is using a powder, that's going to require different dilution. That depends on the type of powder, like whether it's cocaine or a methamphetamine powder. It depends. It really makes a big difference because you have substances like MDMA, Molly, or ecstasy that can cause false positives. And, you know, as much as we don't want to encourage that use, we want to know where that fentanyl is, and we don't want to create a panic. So it's really important that we know for sure, although it's not 100%, so don't quote me on that. So in terms of my own grant, I'm on the State Opioid Response Grant, and as of last year, we got approval from SAMHSA to have fentanyl test strips as an allowable expense. We are working with JBBS to work that in the contract to make it a purchasable line. We understand that it will take time to implement, but we definitely have options, and we're working hard to make that happen. Your harm reduction agencies in your area do have fentanyl test strips. It's a partnership that we are starting to work with CDPHE, Public Health and Environment, and then also our own mobile health units. And this is a plug for my own program. So the mobile health units do have fentanyl test strips on board alongside naloxone. So if you have folks that are releasing and they need test strips, or you run out, or they want connection to buprenorphine prescription, check out our mobile health units and see where their stops are. Every provider should be updating their map and showing a stop. So I understand there's a huge disconnect and linkage of care, or people fall off of their medication. And so we want to make sure that everyone knows about our mobile health unit options. So you'll see the picture here, and this is what it looks like. Tiny little dipstick in the middle. And then on the back, you'll notice the result interpretation. And this is really important because it ties back into different substances need different testing. And that's why you can end up with false positives or false negatives, or invalids, which would probably be the most detrimental, is if you don't know at all, even though nothing's 100%. And then you'll also notice that they do have an expiration date. So this one that I ordered I think I ordered this back in May, so I think it would be about 1.5 years, 2 years that they last before they expire. So I realize that was a very quick presentation, but what questions do you have, or what can I take away from the abstract around fentanyl test strips?
Does anybody, any of the jails on the call, do any of you have difficulty currently getting any getting the fentanyl test strips?
We've never had them here in Delta, but you know, we're pretty limited on a lot of things. It's hard for us to even get the Narcan.
So Brianna, is that
We don't
something
have them in
you-
Route County either. Sorry to interrupt. We
Oh,
don't
no,
have
that's
the
all-
test strips in Route County either. We're looking into it.
Brianna, that being said, is there a way that they could connect with you and we can see about how we can get these
Absolutely.
to those?
Yes,
Okay.
I've been talking to Kelly, or not you, but I've been talking to Jenny, and we've been working out how we can include it into contracts, because it is an allowable expense. So if you order them, that's something you could invoice back to the grant if you're JBBS. And then of course, if you are partnering with harm reduction agencies or talking to them, there might be some alternative ways. There is one vendor out of Canada that seems to be the vendor of choice. We don't have a contract with them, so I can't endorse them, but that does seem to be a very popular choice.
Okay.
And they run about, depending again on the vendor, about $1 a strip.
Oh, that's not too bad. Okay.
Yeah, reducing with bulk order a little bit by fraction or so.
Okay. And I wrote down your email, Brianna. So,
Yeah, and I will include all of this for you as well. You're welcome to share this.
all right. Fantastic.
I was just gonna say, if you can put your email in the chat, Brianna, then everybody will can jot it down, copy it, take a picture, all of the above, just so that we can make sure that you all get connected with her. Great, thank you so much for doing that.
And I'm also going to throw in the mobile health units, just as a way to help coordinate services after release. Any questions about training or something around that? So the best places you're going to find for training are probably going to be your harm reduction agencies, because they are the people in direct contact with people who use drugs. So they are going to have the most up-to-date knowledge on substance testing and how that's working out. And they will also have some trend knowledge, and that's largely anecdotal, but it is trend knowledge, and it is that that underlying knowledge that really informs how we practice professionally.
Fantastic. Any questions from anybody for Brianna? Okay, hearing no questions. We are going to go ahead and end a little bit early today. That was everything that we had for you for this roundtable. Just as a reminder, once the recording is finished, it'll upload, and then we will get it posted on the JBBS website. I would encourage you to check that out as always, and make sure that those who need to know about this are made aware of it. So I appreciate everybody's time today. Thank you all for joining us again. And as always, reach out with any questions to Joel, Becky, or I, and have a good rest of your day.
Thank you.
Thanks, everybody.
Thanks, Kelly.